Hi, so I'm here talking with Betsy Ladyzhets, a co-founder of the Sick Times, and who also writes for some other publications. And so, Betsy, you just published last week a story based on some Freedom of Information documents you got about the NIH's Recover initiative. So, why don't you? I mean, you've covered Recover previously. Why don't you tell us
Yes.
what was new about the information you got this time?
Yeah, so this story was sort of a follow-up to the prior stories about Recover that I had worked on with Stat News and Muckrock, where I used to be a fellow at Muckrock, and now they are our fiscal sponsor at the Sick Times. So still very helpful in working on this story. So what these documents really provided, I think, is insight into how Recover was set up. The documents were two things. One was the applications that the three of the core institutions of Recover, being New York University Langone Health, Massachusetts General Hospital, and Research Triangle Institute, which is a nonprofit research organization. So those three organizations' applications to the NIH to be part of the Recover program, and then also the contracts, or as the NIH calls them specifically, other transaction agreements, which is just like a funky type of contract between those institutions and the agency for their work on Recover.
And
So these documents,
those
yeah,
three groups got the bulk of the funding.
yes, yeah. NYU got the most. NYU received, I think, around half of the original 1.15 billion allocation that was provided to the NIH from Congress. And then Massachusetts General also got a pretty significant amount, like I think a couple hundred million. The exact numbers are in the story.
Yeah.
And then RTI got a smaller amount, but still has been a significant part of, they're the administrative coordinating center. So they're doing a lot of work in setting up and organizing meetings, managing communications of Recover, things of that nature.
And what were there were other applicants though, other than those three.
Yes, unfortunately, the NIH, or at least their FOIA public information officers explained to me that I could receive successful applications, but I could not receive unsuccessful applications.
I
Um,
see. Okay.
because the unsuccessful applications are more of like the property of those institutions.
I
They're
see.
not
Okay.
really
So
public
since they're
records
not,
in the
they've
same.
been rejected, then they're not officially government property in some sort of way that are
Yeah,
released under FOIA. Okay, I get that.
yeah.
Okay, so
However, if anyone watching this wants to send me their unsuccessful recovery applications,
okay.
um,
Solicitation
you
of
know,
documents happening.
yeah,
Okay, so what so you got the applications and you got the contracts. And so
yeah.
you excuse me, then you showed those to various um other researchers and got their input.
Yeah.
What was the general assessment?
Yeah, so I think the biggest conclusion that came out of everybody who helped me review these was that the research teams who were selected to lead Recover did not have the appropriate expertise to be leading this flagship long COVID research program,
I'm sorry, the appropriate,
specifically
you broke up
the
there.
appropriate expertise
Expertise. Okay.
or like research experience. Specifically because, at least as far as the applications and all of the biographies and descriptions of past research that were submitted, there is no mention of the post-viral or infection-associated chronic diseases that we now know are very similar, not similar, but that we now know overlap significantly with long COVID and are frequently co-diagnosed with long COVID. So that's like ME, myalgic encephalomyelitis, dysautonomia, mast cell activation syndrome, EDS, all of these things that we now understand are closely linked and sort of in the same category as long COVID, were not included on these applications. These were not the researchers who were selected to lead this program. And the experts who reviewed these documents were saying this sort of challenge of expertise really underlies a lot of the challenges that Recover has been facing in terms of how the study was set up, how they were engaging with patient representatives and with people who are participating in the different aspects of the study, the selections made for clinical trials that people have been very disappointed with. And all of these things, I think people really just point back to, if they had had researchers who have been studying ME or dysautonomia their whole careers, they could have set things up in a more appropriate manner for studying these complicated conditions and really have moved along the research much
So
faster.
what were their priorities? I mean, what were the strengths they were looking for in the applications, which presumably they had the strengths that they were looking for, if not the ones that the other, you suggest should have been priorities.
Yeah, so I think another conclusion of my reporting is that Recover fits into some broader issues with how the NIH solicits and reviews grant applications just in general. So the NIH is known to have sort of an issue with being very like institutional and slow moving in a sense of they give the same researchers or the same teams or the same institutions funding over and over.
Like you were
And their
successful one
review,
time, so we like you, so therefore
yes,
we'll give you more
yes.
money.
Right. And so it's like these researchers you can see in their applications, they've gotten NIH grants in the past, they've run big clinical research programs. Specifically, these teams, particularly at NYU and Massachusetts General Hospital, had a lot of experience using electronic health records and clinical data and sort of setting up these really just like big data studies. And so that was another part of the expertise that went into Recover. And
The idea
this
being that
creates a challenge.
the idea being they could get answers from big data, even if they
Yeah.
didn't necessarily have the specific expertise in the particular physiological problems they were examining.
Yeah. And some of the experts I spoke to were saying this is sort of there's a tension in this when it comes to long COVID because long COVID is such a and other related diseases like ME and POTS are so complicated that your standard methods of collecting data are not necessarily going to work well. I think people have observed this where, a patient might go in for a standard battery of blood tests and everything comes back normal. So those aren't necessarily useful data points. And my understanding from talking to researchers involved with the observational study is that there has been a lot of trial and error where maybe now they are collecting useful data from the people involved in the observational study, but there's been a lot of iteration over time in the surveys that they're using and the tests that they're doing. And all of that just took a long time to get started because they were doing a lot of learning from like patient representatives and so forth.
So when you say
Um,
I talk about the structure of what they're doing. You mentioned the observational study, and you also mentioned that
yeah.
they were setting up some clinical trials. So what is the overall structure of what's been done or what's being done?
Yeah, so Recover has, it seems like, 5 arms that they generally talk about. There's the observational cohorts, which is what has received the bulk of the funding, at least of the initial funding, which are these significant groups of both people with long COVID and people who are healthy controls, so to speak, who are being followed over time every few months. They're doing medical testing, they're answering surveys, reporting on their symptoms, things like that. And depends on some participants are doing more in-depth testing, some are doing less, but
And
generally a lot of data is being collected over time.
and
And
how large is the cohort? Do we know?
I believe the adult cohort is around 20,000 people, and then there's also a pediatric cohort, which is children, and there is a pregnancy cohort, so people who are pregnant at the time of having COVID or pregnant with long COVID. I don't know as much about that one, so I might be saying that incorrectly. But there are numbers on the Recover website too of these groups. So that's one sort of big piece of it. There's also like pathobiology and clinical research sort of studies aiming to understand the underlying biological mechanisms of long COVID. Um, this ties into the observational research because part of what the participants in the observational research are doing is there are samples being collected that are going into a biobank. And so researchers are able to, I mean, my understanding is this is not happening very much yet, but it will maybe more later. There will be studies using the samples from that biobank to look into like immune system issues, blood system issue, like other things like that with
Right.
long COVID. So that's another piece. There's also electronic health records piece of Recover, which is using data both from Recover itself and also from different medical records associated with long COVID to answer different questions about symptoms, risk factors, stuff like that. And then there is what am I missing? Oh, there's an autopsy study. So that's basically taking samples from people who have passed away, either after having long COVID or
Hmm.
passing away from acute COVID, and then seeing like what changes have occurred in different parts of the body. And then, of course, there is the clinical trials.
Right. And so where do things stand now? I mean, is it your sense that, well, let me ask you this. What have they done well? What would you say?
Um,
What seems to be something that they've done well? Are there positive things we can take from it, that it's not just a loss of 1.15 billion?
so one aspect of the study that a couple people I spoke to were more complimentary of is the pediatric research.
Hmm.
So there is that pediatric cohort that's part of the observational studies. And this is one part of Recover where they're really doing research that has not been done before. I think one critique of the adult observational study is that in terms of collecting data on symptoms and changes to different parts of the body, like plenty of outside research has demonstrated many of these things. So there are questions about like to what extent is it helpful for Recover to be replicating some of this? Some people say it is because it's a large and diverse cohort. Others are more skeptical. I think there's debate about that. But the pediatric study, there is not another study like that on children. So I think that is sort of a unique and useful part of the program that is just starting to put out data. Researchers from the pediatric study presented at a conference a few weeks ago. They shared some new information about how symptoms of long COVID differ by age group. So different ages of children having different kinds of symptoms, and connecting that to things like kids having trouble at school. And so I think there's going to be more research that comes out along those lines that could be very useful to people in the pediatric space. I think also folks are excited about the biobank and excited about all of the samples that are being taken from certain parts of the observational study. Um, there's
So
also just a ton of papers.
the biobank just as a resource is something positive to
Yeah,
have. Whatever
yeah,
recovery itself
exactly.
doing with it, it's a
Yeah,
resource for others to access, and do their own studies
yeah.
with whatever.
Recover recently shared basically researchers can now apply to do analysis of data from the observational studies. And when I sent questions to the NIH for my story, I asked, like, are you going to do the same thing for the biobank? And they said yes, but that's not available yet. So that will be a resource. And there are a lot of papers. The NIH told me there's about 100 pending papers from various parts of Recover that are in process right now. Um, so I think part of this is just sort of a transparency challenge of like, they're not sharing very much publicly in terms of results until all of these papers come out, and the
Right.
scientific review process is slow. So it's hard to sort of say, you know, there have been around 50 papers out of Recover so far. They're all listed on the Recover website. But many of those, you know, if you look at the list and you sort of sort and filter by different categories, many of those papers are just basic data from the observational study, like demographics and risk factors and like how long people have had symptoms. Many of them are electronic health records studies. And so there's not many of the papers that have been published so far are like that pathobiology stuff that people are
I
more
mean,
excited
so
about.
basically what
But
people want,
theoretically, that's coming.
so people want like treatments, people want answers,
Yeah.
right? So is there a sense that Recover's brought us any closer to the actionable things that people really need and want?
I would say based on my reporting, not so far, at least not in terms of like what they have publicly published and shared.
And is that anticipated, or do we not really know?
I think we don't know. I mean, I know one piece of my story that was sort of the end of the story was Recover has received another 500 million or so dollars that was allocated earlier this year from the NIH directly to Recover.
So that
Excuse me.
brings it up to like, so
And people are really interested. Sorry,
that's on top of the 1.15.
on top of the 1.1. Yeah. And so people are really interested to see what's going to happen with that funding. I had the opportunity to interview NIH Director Monica Bertagnoli for this story, and she was saying there's going to be more clinical trials done with that funding. There's going to be more of this pathobiology research. And so I think we'll have to see, how Recover ends up kind of lining up with those statements.
What is the response to the criticisms? I mean, they're obviously aware of the criticisms.
Yeah, they're obviously aware. I think they're recognizing that people are disappointed. I think they're saying they want to be moving with more urgency. But there is also, I think part of the NIH's response to this has been that all of the work of the observational research and the work of setting up Recover with all of the bureaucracy and all of the different committees that are involved and all the patient representatives who are involved, they say that all of that was necessary to kind of lay the groundwork for eventually doing like clinical trials that people are excited about. Sort of saying they had to do a lot of learning from people with long COVID. There have been a lot of patient representatives involved advising different parts of the program, and they attribute like a lot of time and resources to saying that that has been helpful and learning like what are the most important symptoms to people, and that sort of thing. I think people who have been part of Recover as patient representatives who I've talked to have a kind of a range of experiences. Some people find it more valuable. Some people find that they have been more dismissed. It sort of depends on what committees someone has been serving on and like who they're engaging with. So I
In
think
other words, and there
all
seems
of that is very complicated.
some parts of Recover seem more open to patient input than others. Is that what you're sort of suggesting, or depending upon who they're working
Yeah,
with and what the project is?
yeah, and I think some of the patient representatives who have been involved for a long time, I think, um, just have found parts of the experience very frustrating. At least that's my understanding from talking to people. But um, yeah.
So what's next for Recover? Does it continue, or I guess what happens now? Is it what are the prospects? I mean, all the funding that we're hearing about might get allocated. Does that go to Recover, or does that go to other efforts or building on Recover, or what does that look like going forward?
Yeah, so there's the 500 million that I think will be used to, at least the NIH says will be used to continue some of the current parts of Recover and then also support more clinical trials in addition to the 5 platforms that are going right now. And then there are different allocation asks and potential legislation like the moonshot bill that Bernie Sanders' office has put out. Um, all of those could potentially provide more funding to Recover, but also to other NIH offices and other agencies in the federal government. And I think among patient advocates who I spoke with for this story, there's a real interest in sort of saying like, yes, okay, maybe there are some parts of Recover that we want to continue, or that we want to see continue, but people are also interested in like clinical trials and other research that is funded like outside of the apparatus of Recover.
Mhm.
And also other agencies like the Department of Defense, for example, was very involved with Operation Warp Speed, BARDA, AHRQ, like some of these other agencies that have been more involved with quick, fast and efficient clinical trials, or with directly supporting like healthcare infrastructure, which is kind of what AHRQ is doing with grants to long COVID clinics. So people want to see support for all
The
of those
AHRQ is
things.
the Agency for Health Care Quality and
Healthcare
Research.
research and quality, yeah.
It's HHRQ. I always get it backwards. It's HHRQ. Okay.
AH
R.
Agency for Healthcare Research and Quality,
Right. So
and
the
they
Q.
are the one that
And
has provided grants to some long COVID clinics.
okay.
Yeah.
Okay.
So that's another thing that could be expanded.
Okay. Thanks, Betsy, for filling us in. And look forward to more.
Thanks. Yeah.
Okay.